So good to see you. Welcome, everybody. You've found us here at the Silver Hill Hospital Grand Rounds program, and we'll get started in just a moment as people settle into their Zoom boxes. All right, welcome everybody. I am Dr. Jeff Katzman, the Director of Education here at Silver Hill Hospital, and we are absolutely delighted to have you join us today, where we are privileged and honored to welcome Dr. Vivien Burt, who will be presenting on the topic of perinatal treatment of bipolar disorder. I have the absolute pleasure of introducing Dr. Burt in a moment, and the good fortune that we managed to converge this presentation with International Women's Day. So a big thank you and acknowledgement to all the women on the line today and in our lives. It's been a while since we've had a presentation related to women's mental health, so we're happy to be able to do this on this special day. First, a little bit of housekeeping. Our next Grand Rounds will take place on March 22nd with Dr. Gary Small presenting on geriatric psychiatry, the impact of the electronic age on the brain and treating people with dementing illnesses. Back to today's lecture and format. Questions, as you all know, remain a really important part of our Grand Rounds program, and we would love to hear from you. So I'll moderate a Q&A discussion with Dr. Burt at the end of her lecture, and that's your opportunity to put forward questions and comments to Dr. Burt. You can submit a question at any time during the presentation by using the Q&A box, either with your name or, if you prefer, you can submit it anonymously. If you wish to receive continuing education credits, please kindly complete the evaluation survey that will pop up in the browser when the webinar ends. We will also email a copy of the evaluation after the conclusion of the webinar. Finally, disclosures. No planners of this activity have indicated a relevant financial relationship with an ACCME-defined ineligible company whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. So now it is my great pleasure and honor to introduce our guest speaker today, Dr. Vivien Burt. I first met Dr. Burt when she was the Associate Training Director at UCLA, where I was a resident trainee. I would say we had a memorable, sparky, and challenging cohort or group. And Dr. Burt really was a master at working with us, managing our milieu, and she was always a tremendous teacher that we looked forward to hearing from. I really recall her saying back then how important it is to find something that you're passionate about. And she was getting really passionate about women's mental health. She has made tremendous impacts in this area over the course of the years, including working with trainees who I personally have sent her way to shadow, who have gone on themselves to create their own fellowship programs in women's mental health. What could really be greater to know as a teacher than that you've inspired others to teach and to teach other people? Dr. Burt has certainly made tremendous impact through this process of mentoring for myself and for others who I know. So a bit more background about Dr. Vivien Burt. She is a Professor Emeritus of Psychiatry in the Department of Psychiatry and Biobehavioral Sciences at the David Geffen School of Medicine at UCLA in Los Angeles, California. In addition, she is founder and director of the Women's Life Center of the Resnick UCLA Neuropsychiatric Hospital. She's authored more than 50 articles and book chapters, including the chapter on women in the last 5 editions of the American Psychiatric Press Textbook of Psychiatry, most recently published in 2019. She has co-authored the American Psychiatric Press Clinical Manual for Women's Mental Health and has spoken widely on the topic of women's mental health, with an emphasis on perinatal and perimenopausal psychiatry. Dr. Burt has been honored with an Outstanding House Staff Teaching Award from the UCLA Neuropsychiatric Institute, both a President's Award and an Outstanding Achievement Award from the Southern California Psychiatric Society, and Distinguished Service Award of the UCLA Neuropsychiatric Institute and Hospital, and the 2008 Andre Boivin Professorship of the Mother Risk Program of the Hospital for Sick Children in Toronto, Canada. The focus of her activities includes projects in women's mental health, with a particular emphasis on psychiatric illnesses associated with reproductive transmissions. So it is an honor, Dr. Burt, to have you with us today and to get to introduce you and to spend a little time with you. I'm also remembering as I'm talking, actually, that you were my mentor in actually writing my first chapter for the comprehensive textbook where we wrote
Forgot about that.
Both disorders. Yeah, it just dawned on me as I was thinking about that. So thank you for everything you've done in teaching me and other people. And thank you for joining us today. And I pass the baton to you.
Thank you, Dr. Katzman. It is an absolute pleasure and an equal honor for me to be here, particularly, well, because I've heard some wonderful things about Silver Hill Hospital, but also because I know personally how fortunate they are to have you. We've had a long-standing relationship, much of it at a distance more recently, but it's been a joy working with you in every capacity that we've enabled in this relationship. So thank you very, very much. And thank you all for coming to hear me speak about something that is really, really important, because more and more women with bipolar disorder would like to do what a lot of other women want to do, which is realize the dream of becoming mothers. And I can happily say that, unlike the way it used to be, we now are making that possible for most of the bipolar women who come to us, certainly at UCLA in the Women's Life Center. So let me begin by, first of all, letting you know that I really do not have any relevant financial relationships to disclose in relation to this presentation. So what's the true picture of pregnancy? Well, on the left side, you see a truly happy, glowing young woman who is pregnant. She's having an ultrasound, and we like to think that this is the way it is for everyone. And for many women, that is the picture of pregnancy. But on the right side of this slide, you see another picture. And it's a picture of a woman who is nesting, but she's out on a limb. And for many women, that is the way it is for a variety of reasons. It may be because they are currently depressed, or they are currently very anxious. It may be because they have histories of mental illness and have been on medications that have been discontinued or are continued, but they are concerned about the effects. There are many, many reasons that women who are pregnant and have emotional concerns feel just that way, out on a limb. They're nesting. You know, I always say that once you conceive, you are a mother. You feel that way. But if you have an emotional concern, sometimes it's very, very hard to talk about it, and it does feel very isolating. What we in reproductive psychiatry try to do is encourage women to come forth so that we can prepare, hopefully in advance, and make the pregnancy experience a joyful one, but also a safe one, safe for the mom, safe for the fetus, and safe in the postpartum for the offspring as the baby develops into a functioning, fulfilled human being. So let's look at what are the treatment dilemmas that we have when we think about managing bipolar disorder in pregnancy. You have to remember, of course, that there is always the impact of untreated illness on the mother and the fetus, which is so often discounted. We like to think no medications is the best way, but bipolar disorder has an impact on mom, on how she feels, how she behaves, on her ability to avail herself of prenatal care, and also on the health of the fetus. We know, and obstetricians will say it all the time, the most important prognosticator of a healthy outcome in pregnancy is for mother to be well, and that means physically well, but also emotionally well. And of course, being physically and emotionally well is intertwined, and we'll talk a little bit about that. We also know that abrupt interruption of mood stabilizers actually does precipitate decompensation, both in unipolar depression, but also in bipolar disorder as well. And thirdly, we know that all common mood stabilizers carry some risk for teratogenicity as well as potential perinatal adverse effects as well. So these are the treatment dilemmas. How do we negotiate between these three dilemmas as we move forward, helping women manage their bipolar illness through pregnancy and then into the postpartum as well? So the question is, do we treat or don't we treat? And of course, that decision is a matter of weighing the risks of untreated illness against the risks of treatment. And here we apply a concept that in the Women's Life Center, we talk about now all the time. And it's a concept you may or may not be familiar with. It's a concept called satisficing. What satisficing is basically a mushmash, a portmanteau of satisfy and suffice, whereby we acknowledge and accept that the future is inherently uncertain, and that if you expect perfection, you pretty much guarantee disappointment. Most women, when they get pregnant, do not really think of pregnancy as a risky business. But remember, about 3% of the time, babies are born with some congenital malformation, defect that often is easily corrected, but that's 3%. Do we really think about that? Most women don't. They walk into pregnancy and they are just expecting perfection. I think it's important to acknowledge that expecting perfection really always guarantees some disappointment, because nothing is ever the way you think it will be in your imagination. So the goal is to help a patient come to a decision that will most likely produce an outcome she and her significant other can live with comfortably. So let's start by looking at what the trajectory is for bipolar disorder in pregnancy. And here we have an important slide, and it's from the research of Adele Viguera, published in 2007, but it's been reproduced many, many times. And here we're looking at the proportion of women who do not recur versus those that do recur. And these are women with bipolar disorder, those who maintain treatment versus those who discontinue treatment. And what you can see here is there's a dramatic difference that, in fact, for women who discontinue treatment, the relapse rate is substantially higher than those who maintain treatment. Doesn't mean that if you maintain the treatment that works for you, the mood stabilization that works for you, that you won't relapse. But it's much, much higher if you discontinue. In fact, of those who discontinue mood stabilizers that keep them well during pregnancy, 66% relapse in the postpartum period. And of those who continue mood stabilizers during pregnancy, 23% relapse in the postpartum. And what do you think? If you discontinue a mood stabilizer during pregnancy and you march into the postpartum, even if you're well in pregnancy, the likelihood of relapsing in the postpartum is very, very great. Importantly, most recurrences during pregnancy turn out to be major depressive episodes or dysphoric mixed states. And in fact, when recurrence occurs in pregnancy, it occurs early, generally in the first trimester, more so than in the second, more so than in the third. And recurrence occurs earlier if you rapidly discontinue. That is, a 1 to 13-day taper is considered rapid, compared with gradual discontinuation, something more than a 2-week discontinuation rate. Continued mood stabilization in pregnancy clearly reduces the recurrence risk and morbidity during pregnancy. Importantly, bipolar women are at great risk always of postpartum mood or psychotic illness. So we have often seen bipolar women who are quite healthy, who are completely stable, but we watch them very, very carefully during pregnancy and particularly during the postpartum as well, because even if they're well, they are at risk. They're the highest group of women who are at risk psychiatrically during the postpartum. The risk for postpartum decompensation is particularly great after discontinuing mood stabilization treatment during pregnancy. So what do we know about mood stabilizers in pregnancy? And I'm going to review the following medications that have been used to stabilize women with bipolar disorder. I'm going to talk about lithium, sodium valproate, carbamazepine and oxcarbazepine, lamotrigine. I'm going to talk about the atypicals, the atypical antipsychotics, as well as gabapentin. So let's now talk a little bit about lithium. And here what we're going to talk about, because remember, lithium still is, after all these years, the gold standard in treating bipolar disorder. And I'm going to talk to you about a large retrospective cohort study. This was of a Medicaid population, more than an N of more than 1 million, almost 1.5 million, with 663 on lithium and 1,945 on lamotrigine. And 3 groups of women, of pregnant women, were compared. And these were those who were lithium exposed, those who were unexposed completely, and those who were lamotrigine exposed. And the primary outcome that was looked at was the overall cardiac defect rate. Secondary outcomes were right ventricular outflow obstruction, and that included Epstein's anomaly, which is a right ventricular inflow defect, often related to an outflow defect. So it included all of that. The secondary outcome, another secondary outcome, was overall major congenital malformations. So let's talk about the results from that study. Looking at the overall cardiac malformations, the adjusted relative risk was 1.65. That was lithium compared to unexposed. So that's 65% greater relative risk. But what's important is to look at the absolute risk. So for lithium, we're looking at 2.41 per 100 exposures versus 1.15 per 100 in unexposed population, in the unexposed subjects. So remember I said 3% risk of malformations with even unexposed, no background risk in pregnancy. And the greatest risk actually is for cardiac malformations, which is why there is that rate of 1.15 per 100 in unexposed. Many of these can be easily fixed, or they developmentally after delivery get better, but that's what comes up at the time of delivery or within the first year, it's noted. And as I say, many of these cardiac malformations now, thank God, can be easily fixed, and babies can live a normal lifespan, a normal and healthy lifespan. So what we're looking at with lithium is about 1 to 2 additional cases per 100. Lamotrigine, which was the one of the comparison groups, was not associated with any increased risk for cardiac malformations overall. Looking at right ventricular outflow defects, the adjusted relative risk here was 2.66 lithium compared to unexposed. The absolute risk, again, importantly for lithium, was 0.6 per 100 less than 1 per 100 versus 0.18 per 100 in the unexposed subjects. Excuse me, I'm getting over a cold, and you'll have to excuse me if I blow my nose every so often. So that risk is dose dependent, with no right ventricular outflow defects with lithium at doses of 600 milligrams or less. In fact, actually, there was no Epstein's anomaly found in any of the lithium exposed babies. Lithium was found not to be associated with any non-cardiac malformation. Here are these results from that study. And what you can see then is that looking at the lithium, the absolute and relative risks of cardiac malformations at less than 600 milligrams per day, the propensity score adjusted risk ratio was not clinically significant. It was over 900 milligrams per day that you can see that there was a statistically significant increased risk. So what can we conclude from this? Well, the risk of cardiac malformations with first trimester lithium exposure was about 1 additional per 100. The risk increased threefold in doses above 900 milligrams per day. So what can we infer from this? Well, certainly you can consider lowering the dose in the first trimester. You can consider lamotrigine, but often remember lamotrigine is not as effective as lithium, especially for mania. You can consider an atypical antipsychotic, but again, there's less data with atypicals for bipolar disorder. So the question is, do you want to lower the dose in the first trimester? I think that depends on how closely you're watching the patient, how ill the patient is, what her clinical situation is at the time that you're evaluating her, what her history is. Every case is individual and has to be looked at very carefully. Remember, more than 50% of pregnancies are unplanned, and that's probably particularly true and even more so for bipolar women. And it's very hard to adjust the lithium dose after a positive pregnancy test and before the critical window of heart development, which occurs between 4 and 8 weeks post-conception. So you always want to look at every case individually, and it may not be possible to lower that dose, even if you had wanted to, because time has passed till you get to see that patient. And of course, you want to be aware of an early risk for relapse, which is why it's important to remember that the best time to check for how to address a patient with bipolar disorder is before she becomes pregnant. One of the best things that's happened in our program is we have a large percentage of women who come for a single consultation because they have a history of an illness like bipolar disorder and they want to prepare for pregnancy. So psychiatrists will send patients to us for that independent consultation. We then prepare a consultation with our advice, and the patient then goes back to their originating psychiatrist and either comes back to us when they're pregnant or are managed by that primary psychiatrist. Now, what about other pregnancy outcomes with regard to lithium? Here's some data from a study in the American Journal of Psychiatry by Fornaro et al. This also was a meta-analysis where they compared lithium users versus lithium non-users with an affective illness. Most studies that were reviewed were unclear on concomitant teratogenic medication, substance or alcohol misuse. And what they found was that there was no increased risk for spontaneous abortion, no association with low birth weight or preterm labor, and there was this increased risk of any major congenital malformations and cardiac malformations, which was consistent with other studies. Okay. Now, let's talk a little bit about neurodevelopmental outcomes. When we think about neurodevelopmental outcomes, this is a study of 63 bipolar mothers and their offspring, more than 30, who were on lithium prenatally, 33 without lithium. They were not exposed. Why this was a useful study was offspring were evaluated between, at school age, between 8 and 13 years of age. And what they found was, with regard to lithium exposure prenatally, those babies or those children who had been exposed to lithium in their gestation, when they were gestating, there was no effect on brain structure or global white matter integrity. There was also behaviorally no adverse effect on IQ or neuropsychological functioning. So again, very, very important study, because of course we want to see what long-term outcomes are. So let's talk a little bit more now about lithium and what the conclusions are for how to manage patients who are on lithium who are bipolar during pregnancy. Remember, prenatal exposure to lithium does increase the risk for cardiovascular abnormalities, but you really need to weigh that risk against the risk associated with discontinuing lithium and untreated bipolar disorder. Prenatal exposure to lithium does not increase the risk for neurodevelopmental abnormalities, which is something that women worry about so much. The aim then is for the minimum effective dose. Remember, just lowering the dose, but making it less than therapeutic, exposes the fetus to the risks of treatment and maternal mental illness. So what are your alternatives? Your alternatives are valproate, carbamazepine, but remember, they're teratogens. We'll talk in particular, we'll talk about both of those, but in particular, stress valproate acid, which is a major teratogen, lamotrigine, which certainly is safer in pregnancy, but has unclear efficacy for mania. And we'll talk about atypicals, for which there is sparse data for monotherapy in bipolar disorder. So how do we manage lithium in pregnant bipolar patients? Well, first of all, we do what we can to maintain maternal target lithium concentrations at the minimal clinically effective level. If possible, avoid situations that tend to increase levels of lithium. That is, try if possible, not always possible, to avoid NSAIDs, diuretics, ACE inhibitors, calcium channel blockers. Try to avoid sodium restricted diets, which often are needed to manage preeclampsia and edema. So that's something that has to be discussed with the OB. Watch for possible maternal lithium toxicity. Watch for acute fluid loss, hyperemesis gravidarum, and again, preeclampsia. This is where you really need to consult with the OB really at all times and frequently. You want to monitor fetal development. A nuchal translucency, which is kind of an early sign of possible cardiac malformations at 12 weeks gestation. Always a level 2 structural ultrasound between 18 and 20 weeks gestation. And frequently when patients are on lithium prenatally, the radiologist will automatically ask for a fetal echocardiogram. And when that is done in a completely safe procedure, at that point, we can really feel reassured, not 100%, but 99%, that that heart is functioning and functioning well and structurally looks good. So let's talk now about what else we can do to watch for dosing of lithium in the pregnant bipolar patient. We recommend twice daily dosing, even though when not pregnant, dosing of lithium is often done once a day. But we want to avoid peak exposures, so we do twice daily dosing. Check, if possible, the conception lithium levels to guide dosing during pregnancy and the postpartum. And remember, lithium levels tend to decrease in pregnancy because of increased total body fluid and increased clearance by the kidneys. So the dose often needs to be adjusted upward during pregnancy. Now, what guides us is clinically, but you want to do consistent levels during pregnancy to follow, to make sure, to do your best to make sure that levels are therapeutic. You want to monitor those levels carefully once every 3 weeks until 34 weeks gestation, and then weekly after 34 weeks and until delivery. During labor and delivery, you want to maintain fluids throughout labor and delivery. So this is something you want to discuss with the OB and with the obstetric anesthesiologist. And we now believe that you do not have to discontinue lithium, because that's the job of the OB and the obstetrical anesthesiologist, to manage those fluids so that you don't have any toxicity for the mother during and directly after delivery. Lithium is monitored in the mother twice a week during the first 2 weeks after delivery, with the goal of achieving preconception lithium levels while at the same time maintaining clinical stability. We're going to talk about something very, very important now, and that is valproate during pregnancy. I can't emphasize enough that sodium valproate presents a very, very, very high risk for serious adverse outcomes with prenatal exposures. And among those serious adverse outcomes are spina bifida, assorted craniofacial defects, including oral defects, a whole host of other defects, heart defects, polydactyly, hypospadias, low birth weight, and then very, very importantly, cognitive developmental delay. And I will talk to you about the risk for mental retardation, and it is significant with valproate use in pregnancy, as well as for autism. The risk for valproate is highest if valproate is combined with other anticonvulsants. We know this data not just from bipolar patients, but also largely from patients who are being treated for seizure disorder. So what do we do in the event of exposure to valproate? Because we do see patients who come to us who are pregnant, who are on valproate, who have been exposed, and they are, as I say, pregnant. Well, in the event of exposure, clearly we need to do an amniotic alpha-fetoprotein at week 16, which, when it's high, it is highly suggestive of a neural tube defect. An ultrasound is done to check out all parts of the fetal body at weeks 18 to 20. Women of childbearing potential need to be informed of the potential for serious fetal risks before administered valproate. And we're going to talk quite a bit about this in the next few slides. So let's talk a little bit about cognitive functioning at age 3 after a child has been exposed in utero to valproate. At 3 years of age, children exposed to valproate had significantly lower IQ scores than those exposed to other anti-epileptic agents. And that means at age 3, 9 points less than the average IQ of 100. And these results were independent of the mother's IQ, mother's age, the gestational age at birth, and maternal use of folate. We'll talk more about that in the next few slides as well. The association between valproic acid and IQ was dose dependent. So the higher the dose, again, the more likely there was for cognitive delay, cognitive function problems. And that also is a tip-off that this is clearly a valproic acid problem. So Should valproic acid be used in women of reproductive age? And here we have experts disagreeing, because obviously we want the best treatment for a bipolar woman. At the same time, a lot of these women are of childbearing age. What do you do? Some say yes, and some say no. So what can we say about this? Well, the reality is that valproic acid is associated with unacceptably high rates of major malformations and neurodevelopmental disorders. We can't argue with that anymore. That is the data. We also know unplanned pregnancies are common, and women with psychiatric disorders are more likely than the general population to have unplanned pregnancy. We then believe that valproic acid is not a first choice in a woman of reproductive age, and we try to consider treatment in the context of a pregnancy in the future. So clearly what we, and again, there's a lot of discourse about this, but in my opinion, first-line options should include medications which are appropriate for a given clinical situation, while also considering reproductive safety data. So here we have this dilemma. What about the patient who does well on valproate, not on lithium, and valproate keeps her completely stable? What do you do? And this is a patient that we might keep on valproate, but then might consider changes in pregnancy with very, very close reproductive care. We can talk about this in the Q&A if you like. This is a real conundrum and a debatable subject. We'll talk a little bit more also at the end of this lecture. What about carbamazepine in pregnancy? Here, the data comes from the Eurocrat data set, which is a European surveillance registry of congenital abnormalities. And this is a combination or conglomeration of 19 European population-based teratogen services. And this included 98,000 registrations of malformations covering almost 4 million births. And the data shows us that first trimester exposure to carbamazepine with a monotherapy was associated with a 3.3% risk of major congenital malformations. And so you can see that is marginally above the background risk of 2 to 3%. And the risk for spina bifida was 0.2%, far less than for valproate and slightly more than the background risk of 0.1% with no exposure to anything. And there was no increased risk for adverse effects on IQ. With regard to oxcarbazepine and pregnancy, we don't have that much data. It's a much smaller study. This is a Cochrane review from 2016 with an N of 238. A prevalence of major malformations was 2.39%, which again looks pretty good. The EURAP data, which is again a European International Registry data, again, here the N was 333 and the major malformations was 3%. Not that different from the 3% general population increased risk. But remember, you really need an N total of over 500 with a goal of 600 to 800 exposures to say definitively that the risk is minimal. But the signal is that this is not that different from carbamazepine. With regard to long-term exposures, a lot less data. A review of 5 studies showed an increased risk for autism of 13.51. But again, we really can't interpret the data. Look at the CI, which was 1.28 to 221. So the confidence interval was very, very wide, the variability too great to really interpret the data. But the signal doesn't look too harsh, at least for both oxcarbazepine and carbamazepine. What about lamotrigine monotherapy in pregnancy? There was an earlier concern for oral clefts, but Numerous studies and a large meta-analysis have found no evidence for significant increased risk for oral clefts relative to other non-chromosomal malformations. The absolute risk of oral clefts was 0.7%, less than the risk for prenatal bipolar decompensation without mood stabilization. And again, we need to keep bipolar women well emotionally. There was no increased risk for adverse pregnancy outcomes, no increased risk for gestational age babies, no increased risk for miscarriage, no increased risk for stillbirth or preterm delivery. Now, one thing we do have to remember is that estrogen rises during pregnancy, and that enhances lamotrigine clearance through P450 induction. So that may result in subtherapeutic concentrations in maternal serum over the course of pregnancy. And that becomes really notable by week 10. Now, this does vary from patient to patient, but we do know that levels of estrogen rise and lamotrigine levels often decrease during pregnancy. So we may need to alter lamotrigine dosing in pregnancy. At the same time, levels of lamotrigine return to pre-pregnancy values within 3 to 4 weeks postpartum. So when it comes to dose adjustments, dosing may be necessary then to maintain clinical response during pregnancy. But remember to be careful of postpartum toxicity if the dose isn't returned to pre-pregnancy levels. And signs of lamotrigine toxicity are diplopia, ataxia, nausea, dizziness. So if possible, try to get a trough lamotrigine level before pregnancy or soon after conception when the patient is at a therapeutic dose. Check the levels and the symptoms of the patient to keep the patient well postpartum, and taper the dose postpartum day 5 through day 14 to get back to optimal pre-pregnancy doses. Now, what about folic acid supplementation to reduce neural tube defects? Now, universally, for all women, whether they have an emotional illness or not, the recommendation is 0.4 milligrams of folic acid daily, beginning 1 month prior to attempting conception and continuing throughout pregnancy. For women at high risk of offspring with neural tube defects, maybe women who've had a history of a neural tube defect in a prior pregnancy, or women who are on medications that put them at risk for a neural tube defect, the recommendation is 4 milligrams of folic acid 1 to 3 months prior to conception and maintained for the first 12 weeks of pregnancy, after which the dose can be reduced to 0.4 milligrams daily. This is an important slide because what you can see, this is a slide that looks at cognitive function, again, in 6-year-olds, so these are school-age children, after fetal exposure to anti-epileptic drugs, both with and without folic acid. The folate is the solid lines. Without folate, on those anti-epileptics is the dashed line. And so we compare carbamazepine to lamotrigine, to phenytoin, to valproate, and to all of those, to poly use of anti-epileptics. And what you can see is folic acid what does not protect against valproic acid adverse effects. And here, see, this is folic acid. Whoops, sorry. Yeah, this is folic acid with, this is valproate with folic acid, and this is without. So yes, it's slightly more protective, but you can see how concerning it is, valproic acid during pregnancy. It has a substantial effect on mental retardation. It increases the risk for mental retardation. Looking at these others, folic acid, what you can see is with folic acid, you do have a substantial protective effect, which is why the recommendation for 4 milligrams prenatally during the first 12 weeks at least of pregnancy. Let's look a little bit more now at other medications during pregnancy. And here we're looking at atypical antipsychotics. And we have data, good data, from the National Pregnancy Registry for Atypical Antipsychotics. And here are the conclusions regarding reproductive safety of these agents is very good. Currently available data does not suggest a signal of teratogenicity. Looking at a large prospective cohort study in Japan, which compared exposed versus unexposed pregnant women. Again, currently available data does not suggest a signal of teratogenicity at all, okay? And the results suggest that in pregnant women with serious psychiatric illness, using atypicals may be the best choice to keep a patient well. And we use atypicals quite frequently in bipolar women as an adjunctive medication during pregnancy. Looking at this next study, looking at atypicals and neurodevelopmental outcomes. And again, this is a birth cohort study with an N of over 10,000 with prenatal exposure to antipsychotics in the second trimester. This is when brain synaptogenesis occurs primarily. These offspring were assessed at greater than 8 years of age. And looking at the adjusted data, there was no statistically significant association between prenatal antipsychotic exposure and controls when it came to ADHD, autism, IQ, and intellectual disability. Very, very reassuring data. Now, in that study, only aripiprazole was possibly associated with an increased risk, with a hazard risk of 1.36. Now, that's somewhat concerning. We do need to replicate that study because remember, this looks at association, not causation. And also just some thoughts, aripiprazole at the time of the study was a newer antipsychotic. So perhaps the women who were on it had more severe illness. There was also no information on breastfeeding, and aripiprazole, remember, reduces dopaminergic dopaminergic transmission through D2 partial agonism, and so that may decrease lactation. We also worry about confounding by indication. They never looked at family environment, genetic predisposition in the setting of mental illness, although that would apply to all the other antipsychotics that were studied as well. So the only thing I would say is that patients with serious bipolar disorder who are stable on aripiprazole only, I think you will discuss it, but the risk may lean in the direction of continuing aripiprazole. However, in patients who have not been exposed to antipsychotics and you're making a decision, I would, at this point, maybe veer a little bit away from aripiprazole. And I'm just looking at this slide and I see there are a couple of typos. I apologize for that. So, remember also when it comes to atypicals, there has been an FDA labeling change in 2010 and 2011, including all typical and atypical antipsychotics. And they suggested that you watch for symptoms, including agitation, increased or decreased muscle tone, tremors, sleepiness, breathing, and feeding difficulties. So what the suggestion is not to avoid it, but to observe these babies in a special care nursery for about 2 days postpartum. Almost always, almost invariably, these babies do well after the first few hours. So looking now at gabapentin, this is data from a large population-based study. And again, in this study, there was no evidence of major malformations, a slightly higher risk of cardiac malformations with a relative risk of 1.40 when exposures to gabapentin were restricted to 2 or more filled prescriptions. Now, this could be due to confounding by indication. Late-term use of gabapentin was associated with a small risk for adverse outcomes, but risks were also found in women with depression and anxiety, and these included preterm labor, small for gestational age, and NICU admissions. Now, I always remind people that gabapentin is not a first or second line treatment for bipolar disorder, although it has been sometimes used for sleep problems and anxiety. If you can avoid this in bipolar women during pregnancy, I would suggest trying to do so. If you can't, watch carefully. And again, you want to make sure that these women are protected from bipolar relapse, particularly as they walk into the postpartum. I also suggest there are 2 articles that were written by me and some co-authors from the Women's Life Center. Both of these were published in the Washington Post. One of them is a Washington Post article on parenting. The Good Enough Mother Begins in Pregnancy, and it deals with with the whole issue of should we use medications in pregnancy. And the second article is an article on breastfeeding and medications and whether or not you want to continue breastfeeding or not. And it's Doctor Says Breastfeeding, Your Health and Happiness Matter as Much as Your Baby's. These, I think, are useful articles for patients that you can, there are links for them. Just look up the author and the title and you'll get the links, and you can give this to your patients. Now, just to summarize, psychotropics in pregnancy, are they friend or foe? Just remember, the wise clinician in the real world knows and acknowledges the risks of medications in pregnancy and weighs these against the risks of untreated illness on fetal and maternal health. Remember, no decision's risk-free, and individual cases require individual decisions. And we're looking at a team decision, the psychiatrist, the therapist, the family, and the OB and the pediatrician. I'm going to take the next few minutes very briefly to give you a real case vignette. This is Mrs. M, 29 years old, bipolar, diagnosed at age 18. She had a history of lithium-induced hypothyroidism. She was very ill. She had 6 psych hospitalizations between the ages of 18 and 20. And she was very sick. She had suicidal mixed episodes. She's been stable, however, since age 22. She's now writing her Ph.D. thesis. She wants to have a baby. She has rejected surrogacy. She's married to a successful attorney for 3 years, and she has a very supportive extended family. Her current medications include quetiapine, lithium, Lamictal, and levothyroxine, and Demulin for birth control. She's come to us for a pre-pregnancy consultation. And we have this team approach that I told you about. Everyone was involved. The patient really wanted to stop lithium. This is a number of years ago. We said we didn't think she should, but she was worried about even the slightest cardiac risk. So we didn't fire the patient. The decision was to taper her off and monitor her clinical status. We suggested rest, good nutrition, exercise, and if she was stable for 6 months, attempt pregnancy. So her lithium was tapered over 3 months. She continued her Lamictal, her quetiapine, her thyroid medication. She was supplemented with folate. However, when she got down to 300 milligrams per day of lithium, she became depressed, despondent, suicidal. She had a mixed episode. She was hospitalized urgently, psychiatrically. Her lithium was calibrated back up to 900 milligrams per day. After 1 week, she was somewhat improved, quite improved, and she was discharged and followed very carefully from home. 10 months after that psychiatric hospitalization, with its 6 months of stability, conception was attempted. She was now on lithium, quetiapine, lamotrigine, folate, and multivites. 7 months later, after that 10 months, she conceived. However, at 6 weeks gestation, she miscarried. The embryo was evaluated, and a chromosomal abnormality was found, not thought to have anything to do with any of her medications. She was clearly depressed because she had wanted to have a baby. Lithium was increased, the dose was increased, quetiapine dose was increased, the lamictal dose was increased. 4 months later, she conceived again. A first trimester ultrasound showed a possible cardiac abnormality. She had a somewhat high nuchal translucency. However, a high-level ultrasound at week 18 showed no sign of major malformation. A fetal echocardiogram was done. At 22 weeks, it was normal. Everyone was reassured. She had weekly psychiatric visits. Episodically, she was dysphoric and irritable. She had a brittle bipolar disorder illness. Her psych meds were adjusted. By the second trimester, she had episodic irritability. Her maternal serum lithium declined, as we expected. Her lithium was increased. Her lamotrigine levels were had decreased over time, so lamotrigine was increased. By the end of the second trimester, she had gained weight. There were fetal movements. OB parameters had improved, but her psychiatric status worsened. She was more depressed. The team decision was to increase her quetiapine. Her status psychiatrically did improve. Now we're into the third trimester. At 28 weeks, she developed gestational diabetes. You wonder, did that have to do with the quetiapine? Who knows? She was managed with insulin. At 30 weeks now, fetal movements stopped. She had fetal decelerations, signs of placental degradation, and abnormal fetal non-stress test. Very, very concerning. She was admitted to the OB unit, strict bed rest with monitoring. The dilemma is, could this have been due to polypharmacy? We don't have data about polypharmacy. Did this contribute to what was going on? The decision now was to decrease the quetiapine from 300 to 200 milligrams, continue the lamotrigine, continue the lithium. Her level was now therapeutic at 0.6, and betamethasone was started to treat lung immaturity if she had a preterm delivery. At 36.5 weeks, she had premature rupture of membranes. A C-section was done. She delivered a baby girl with good APGARs of 7 and 8. The baby did have some transient difficulties post-delivery, transient respiratory difficulties, but she was stabilized rapidly after 12 hours. She was put back in her room with mom, no breathing difficulties. She did have some somnolence, some lag in sucking, but that resolved over several days. And by a week, the baby had fully normalized. Maternal postpartum course, overnight and daytime. She had a baby nurse. She did not breastfeed because we wanted all the help she could get and for her to get rest. Her diabetes fully resolved and her obstetrical recuperation was unremarkable. Quetiapine, lithium, lamotrigine continued into the postpartum. At the first postpartum month, lithium and lamotrigine dosing was readjusted to achieve pre-pregnancy levels. At 4 months postpartum, she had bonded well with her infant. She felt competent to care for her baby. She was gratified, calm. She was very loving towards her baby. But remember, this is why this is such a difficult topic. There were a lot of questions that were raised by this case. There was polypharmacy with a dearth of data in pregnancy. Obstetrical complications raised issues about what to do psychiatrically. Psychiatric complications raised issues about what to do obstetrically. Again, how do we deal with this? With a team approach and an open, transparent relationship with everyone concerned. access to a perinatal psychiatric consultant is very important, especially in cases with stiff, brittle illness like this patient. Having a supportive family, friends, and community is important. And if you can manage it, financial resources to allow for lots of help and multiple care providers. So let me just move on quickly. Reasonable treatment approach, lithium, lamotrigine. These have well-characterized reproductive safety profiles with low absolute risks. Lithium's a good choice for women at risk for mania. Lamotrigine's a good choice to prevent bipolar depression, but not mania. Atypical antipsychotics, the data is growing, but they don't appear to be teratogenic. All mood stabilizers then carry some teratogenic risk. Some also carry peripartum toxicity. Atypical antipsychotics, early data reassuring for teratogenicity. Treatment choice is made case by case. Use the safest choice to minimize maternal mood stability and fetal safety. And remember, there's no simple decision for a psychiatrically ill pregnant patient. Having said that, I'm going to invite Dr. Katzman to have a few words and hopefully bring forth some Q&A that we can answer.
Thank you so much, Dr. Burt. That
My
was
pleasure.
beautiful.
Thank
I
you.
love hearing your cases so much. I was sitting there thinking, I hope you're going to present one of your cases that make me actually so fearful. I start imagining what it's like treating these. It's such difficult.
It's a team approach.
decisions.
That's key.
Yeah. Which brings up my first question. Before I get there, actually, I just encourage people to put questions into the chat, and I'll start us off with a couple questions. Do you recommend in general a general adult psychiatrist who's treating a patient, say in their clinic, who is pregnant, to consult with somebody with expert in the perinatal treatment of pregnant women? Like, should that be something that's routine for
I
people?
think so. I think I wouldn't say, again, everything is individual. You have a patient who's had a unipolar depression when she was 20 in college, broke up with her boyfriend, was treated with an antidepressant, and she's just been treated with Prozac, with fluoxetine for years. She's now 33 years old. She's contemplating a first pregnancy. She's rock stable. She's functioning beautifully. I don't think you need a perinatal psychiatrist for that patient. You probably will taper off the fluoxetine, which she may not have needed. Watch her for 3-4 months. If she's completely stable, she should go ahead and be pregnant. And her psychiatrist should watch her just to make sure that she's okay through pregnancy and the postpartum. Maybe a once a month check during pregnancy, and then maybe a little closer check during the postpartum. If she's done well over 3 months, she's fine. That's a very different situation from the case I just presented, where absolutely that patient needs a perinatal psychiatrist. Now, that perinatal psychiatrist does not necessarily need to follow her, but should at least consult periodically and work with the psychiatrist that the patient is most comfortable with. But could follow her if that. It could be that the primary psychiatrist isn't comfortable, wants to take back the patient after pregnancy and after the first few months postpartum, and then the perinatal psychiatrist will do that. So that again, look at each case individually.
Yeah. Given I've heard you say many times too, this is such a rapidly evolving science, and one of the most important things to do is to stay up on it. So to that, I'm assuming kind of the teratogenicity and side effects of medications, of new medications, also continues to evolve. How do you handle, I guess, issues of kind of protecting against future legal actions from patients who are, I don't know.
Well, because things happen.
Things
happen. I mean, there are tragedies that happen. Babies are born with maybe a serious cardiac defect, or or maybe have a behavioral neurobehavioral abnormality, and you have to do so. It can happen. I have to tell you, I've never been sued
Mm,
for that
mm.
ever. And nobody, and I've now, this clinic is 30 years old. Nobody, never once has there been a suit in our clinic. Never once.
Pretty amazing.
It is amazing, but I
Yeah.
really believe it's that close connection
Uh-huh.
between patient and doctor. And whatever you document, now it's pro forma, everyone is available, records are available to patients, I think, throughout the country.
Mm.
That was not the case until about 3-4 years ago. We always, 30 years ago, we supplied our patients
Mm.
with a copy of our consultation with our treatment recommendations and justification for why we have recommended that. That's as important as anything. Because if we're saying that lithium incurs an extra 1 per 100 possible risk of a cardiac malformation, but we're recommending continued treatment with lithium, and we provide data for that suggests that risk, we also have to justify why we're still recommending it.
Mm-hmm.
And that's what we do. We say, very strong history. There's a family history. When the patient has been on lithium and has tapered off it, she has recurred and had to be hospitalized. I mean, these things all have to go into not, so it's one thing to recommend. It's another thing to document how we justify those recommendations.
Mm-hmm.
That's the key.
Mm-hmm.
So if there ever was a suit, if it's 10 years ago, I may not remember that patient exactly, but it's my thinking went into the write-up.
Mm-hmm.
My thinking. So let somebody, if I were on trial, I will say, here's why we recommended this.
Mm-hmm.
And we were transparent with the patient. The risk of her decompensating and becoming very ill, one of the things, I don't want to take up too much time, but one of the things that used to happen is that bipolar women would come, this is years ago, would come to us having had several abortions, therapeutic abortion, selective abortions, I should say, because they became pregnant. They were on a medication like lithium, and they were inadvertently, and they became terrified that there would be a problem. These were women who wanted to have babies. I think this is not a commentary politically about abortion. This is about ending a pregnancy in somebody who wanted to have a baby. That's a bad outcome, isn't it? To end the life of a fetus when maybe it wasn't necessary, and the mother, had she been counseled properly, could have had a very healthy, successful pregnancy and outcome. So that's a bad outcome, in my opinion.
Mm-hmm.
Worry about side effects. Well, that's a bad side effect.
Here's a bunch of questions are coming in. Thank you. More as I talk, so I'll get to them. The first one is this from an anonymous attendee, says, "Hi, Dr. Burt, exclamation point. I was wondering what might be some of the reasons why bipolar women feel stable or well during pregnancy. Could it be that the accomplishment of a desired pregnancy has a positive impact on them and symptoms are reduced? I'm thinking in terms of what could explain a higher relapse rate during postpartum. Thank you very much."
Yeah, that's a very good question. That's something that it's very hard to account for, but we do know, we have those studies that show that if you discontinue a stabilizer, mood stabilizer that works in pregnant women, and we have these are controlled studies, the relapse rate is high during pregnancy. Relapse rate is high during pregnancy. And that makes the relapse rate particularly high during the postpartum. The other thing I will say is that for every woman, the postpartum is a stressful period. You could be delighted, you could be happy. I understand all the actresses in People magazine, they're just so delighted, and you see all these shining, happy women, just like that picture I showed you. But the reality is that It's a stressful time. I don't care how easy your delivery was. It's a physiologically stressful experience. You're not going to be exactly as you were pre-pregnancy. It takes time. You're tired. You're stressed. Babies are generally very nice and quiet in the hospital. When they come out after a few weeks, a week or two, they cry a lot. And sometimes especially if you're a new mother, it's hard. And if you're bipolar, you need your sleep. And if you're trying to do everything, and maybe you are financially stressed, and maybe you don't have the most supportive environment, it's going to be stressful. So I think invariably you really have to, better to err on the side of caution and say to yourself, bipolar, postpartum, high risk. What's the worst that can happen? Everything's great.
Yeah, thank you. So along these lines, Jillian Tan says, thank you for this presentation. What are some of the risks of non-treatment that you counsel patients about when making these decisions? What do we know about how untreated mental illness affects a fetus beyond behavioral
Yeah,
risks?
well, I didn't go over all the data for that, because how much can you do in an hour? But
Right.
there is data, there is considerable data, both in animals, but now increasingly in children, that maternal mental illness during pregnancy, before pregnancy, after pregnancy are big risk factors for poor outcome in exposed children. And I mean exposed to mental illness, exposed either in pregnancy, epigenetically, either in the postpartum, and genetically. So we know that this is why we talk about confounding by indication, that often we blame a medication for a poor outcome when it's the reason the person was taking the medication that caused the poor outcome. We know that depression is a heritable condition. Bipolar disorder is a heritable condition. Many of the anxiety disorders are extremely familial. OCD, I haven't even talked about some of the other things that we address in our program. So I don't think you should treat these lightly, that family history is important, personal history is important. One of the things I always say to my residents, we'll see new patients and they look terrific. They're the people you would want to invite to your home for dinner if they weren't your patients, but they have horrible histories. Please don't forget the history. Think about it, protect, and be transparent about why you're doing that with the patient.
Thank you.
Now, having said that, there are patients who insist on not being treated with medicine, and we don't fire those patients. We follow them because we want to be there if they decompensate. And if we're proven wrong, wow, terrific, great.
Thank you. There's a couple of comments here about the idea of one key question and how one key question is being integrated into care to screen client preconception. Do you know about that?
No. Can you tell me about it? I don't know what that is.
I don't know. Maybe if the person wants to send it in. I think one key question asks all health providers and champions who support women to routinely ask, would you like to become pregnant in the next year?
Oh, okay. Yeah, absolutely. That's a very important key question. And you can be sure that that's important for health providers throughout, and especially for those of us who are psychiatrists. And when you see a patient who's 25 and not in a relationship, pregnancy is far, far from her mind, you think to yourself, tomorrow she might meet the right person. She may change her mind. And that influences the decisions you make, for example, with valproate and other things as well. Very good point, though. Thank you.
Are you, Jennifer Vendetti says, Dr. Burt, are you hopeful that the workforce of reproductive psychiatrists will increase And another question here is, do you know of a counterpart to you on the East Coast?
I know of lots of first of all, first question, yes. We know more and more. Actually, let me tell you that we know a lot about antidepressants. We know a lot about the medications I've just talked to you about, but there are new medications coming out, and we'll have to know more about those as well. But counterpart, sure. On the East Coast, there's a burgeoning subspecialty. We're going to eventually get to making that, like geriatric psychiatry, a board certified subspecialty. It's not that yet, but it is a subspecialty. And I'm on a national board that's looking at doing that, of getting this board certification status. And you can think of Mass General as one place in your community, well, not that much in your, but where someone can get a consultation. There is the Women's Mental Health Program there, led by Lee Cohen, which would be a wonderful resource.
Thank you. Thank you. Stephen Weisblatt is asking about the use of NAC pre and during pregnancy as a nutraceutical that may contribute to the maintenance of mood stability. Do you have any ideas?
There's no data. That's the problem. We have no data for that. Mm-hmm. And so when you have no data, I try to discourage it, because even over-the-counter stuff, you don't know what the side effects are. You don't know what they're corrupted with. So I always am very cautious about that.
Mm-hmm. And he also asks if you can address the risk of teratogenesis as being different on different trimesters.
Yes,
such as carbamazepine may be usable during later trimesters.
Yes, absolutely. Absolutely. So, when you think of neural tube defects, you think of the first trimester, early first trimester, but also do remember that synaptogenesis in the brain, that goes on through pregnancy, all 3 trimesters. So it's a concern, less so with carbamazepine, but you do have to realize that the brain continues to develop after delivery. That's why, babies are not born thinking the way they do when they're adolescents, when you wish they were thinking differently even then. But so I think you have to look at now, when it comes to heart defects, oral clefts, a lot of the other, GI, most of that is done in the first trimester. But neurologically, things go on throughout pregnancy.
Mm-hmm. Thank you. Another anonymous attendee says, a patient who is very stable prior to pregnancy and stable during pregnancy with a history of mixed bipolar disorder, would you start her on a medication postpartum or watch her mood stability?
If she wasn't on a medication during pregnancy, you bet I'd watch her very, very carefully. I'd look at the history, because I might, it depends on the history and how recently but if she's completely, and here's where you have to listen to the patient too. If she doesn't want to be treated with a medication, I'd say, okay, but I want to follow you. I'd like to see you every week for the first few months postpartum, or have a therapist who's well-versed, who can then, and I would see you once a month, but the therapist has a clear avenue to talk to me. Again, everything is individual, but I would watch. I have to tell you, bipolar, if it's a true diagnosis, bipolar disorder is very concerning in the postpartum. Nothing to be scared about, because you can help these people, but it's the reality.
Another anonymous attendee says that this may not be part of your research expertise, but is curious to know if you've heard of any research regarding whether a diagnosis of maternal gestational diabetes or even prediabetes can trigger mood disorders in infants who may or may not be genetically vulnerable to mental illness.
Never heard of that, never seen any data about that. So, but again, and I don't know that any research has been done there, because it probably would have popped up, but I don't know anything about that.
Right. And Kenneth Burrs shares a story to kind of back everything you're saying, who says, many years ago, I had a patient with severe OCD who responded well to 120 milligrams of fluoxetine. She wanted to become pregnant, and I sent her to the Mass General for a prenatal consult. She remained on the medication, became pregnant, and had a full-term normal pregnancy and delivery. The baby had a few hours of mild stiffness, but otherwise was normal. When I spoke to the obstetrician and said she made it, he respected. I couldn't have made it without her taking the medication.
Exactly. That's OBs do not want to deliver emotionally unstable patients. They don't want that. They say, you do your job, we'll do ours.
Mhm.
I've
He
heard
adds,
this many, many times.
he adds that she moved away, but has sent me a Christmas card every year, recently with a picture of her entire healthy family
Yeah.
of 4 children. So to your point.
Yeah. You know, I wrote an article a long time ago. It was in the American Journal. It was a clinical case study. And this was really, it has to be, let me just think, how old are her kids now? So it was maybe 30 years ago, because her 2 of her oldest children just got married. Orthodox Jewish woman with OCD. And she had bad OCD. And at that time, it was fluoxetine that we used. And that was pretty much the only antidepressant we had any data for. And it wasn't much. And I told her that we didn't have much data. And she said, look, my whole life is having babies. I can't do that unless my OCD is taken care of. So you treat me so I'm well, so I can do what is the most meaningful thing in my life. And she subsequently went on to have 5 brilliant, healthy children, very brilliant, healthy children, all of whom are highly successful.
Patricia Francic says to please mention bipolar patients who choose IVF due to being unable to get pregnant naturally, who are also refusing medication. And then adds DCF. I'm not sure what that means.
DC. I don't know. Well, okay. There are patients who will ask us, is it safe to take medications when I'm doing IVF? And the answer is we have no data suggesting that it is not. And it's often very important if you need medications during pregnancy to take it during IVF, because IVF is very stressful. And there's often some disappointments here and there until hopefully success. And patients are hormonally primed. And some patients are very, very susceptible to hormonal vicissitudes that affect mood and anxiety. So reproductive endocrinologists work with us all the time so that patients are treated through the IVF process.
I think we have time for one last question sent in. I wonder how they can compare or know that there's no subtle or any impact on the brain or IQ, et cetera, with a child not knowing about a medication.
It's the best question, because that's what patients say. Can you guarantee?
Mm-hmm.
And the answer is, I can't. But what I can guarantee is, given your history or your current situation and the data that we have, and there is plenty of data that suggests that if you are not emotionally well, your child is likely to have emotional illness, may have disturbed thinking, will have behavioral abnormalities that will impact that child, not just as a child, but through adolescence and into adulthood. The data, there's a wonderful piggybacked article by the STAR-D study by Marina Weissman that showed that these children who are raised by women who are not sufficiently treated at all times, but particularly in the postpartum and beyond, that these babies, these children, often they're more likely to be divorced, have poor relationships, have substance abuse problems. We know that. So can I guarantee no subtle change? Nope,
Mm-hmm.
I cannot. But you know what? Let me just finish by saying this. I'm old enough to tell you that my mother smoked throughout my pregnancy. And I often used to say to my mother, you see, I could have been 5 IQ points higher. And her response was, who cares? You're smart enough, too smart. And I wish you were 5 IQ points lower, because you always have an answer for me. So yeah, she smoked. I wish she hadn't. She shouldn't have, but she knew better. That's what everyone did in those days. So what can I say?
Yes. Vivien, it is so great to see you. Thank you so much for sharing your wisdom and really enlightening us about the whole field of what you do.
It was my pleasure, and thank you for having me. It's been an
Yes.
absolute pleasure and great questions.
Yeah.
And thank you, Dr. Katzman. It's been great working with you again.
Yes, likewise. And thank you, everybody out there, for joining us today. Let me remind you that if you wish to receive continuing education credits, just complete the evaluation survey that will automatically pop up in the browser as the webinar ends. You know, we've all been really engaged here in a conversation, and I like to say that's a little abrupt when we all end and find ourselves in our own room and back to work. So great to see you all. Happy International Women's Day, and hope we can all acknowledge that in some way.
Yay, women.
Yes. Thanks again. Yay, women is absolutely right. Thank you. Thank you so much again, Dr. Burt. And this concludes our grand rounds, everybody. Thanks, and
Bye, everyone.
see you next time. Bye-bye.